Hello, everyone, and welcome to another workshop of the Unity Conference. Thank you, everyone, for joining. My name is Aurora Grant-Wingate, and I am NACHW's Member and Partner Engagement Coordinator. And I have the pleasure of introducing three brilliant presenters for today's workshop. This workshop will have 2 sessions, each lasting 30 minutes. At the end of each session, there will be time for folks to raise their hand and ask questions of the presenter, but please leave those questions till the end. The first part of our session is about capacity building strategies for CHWs via Department of Labor Apprenticeships, an overview of ASPIN's Opioid-Impacted Family Support Program, presented by Paul Conrad. Paul Conrad overseeing ASPIN's workforce development programs. These currently include the ASPIN Chronic Care Education and Paraprofessional Training Program, the ASPIN Opioid Workforce Expansion Program, and the ASPIN Certified Community Health Worker Training Program. Paul is also currently an ambassador of NACHW, and I'll hand it over to you, Paul. Thank you.
Thank you, Aurora. Wow, I sound like I'm really busy. Thank you all for attending. I'm a former history teacher, so I have to give some history before we dive into the actual program. But the reason I'm doing that is because we really need to review how we got to where we are. I'm very excited about this program. It's fairly new, but we didn't just think it up and just dive in. So it was a process. So let me give you a little bit of background on who ASPIN is and how we got to where we are with this particular program. ASPIN is a 501(c) nonprofit network. We have 4 different service lines. We do behavioral health service, professional training and workforce development. That's the program I'm over. We do grants management and health improvement. And as you can see there, our mission is to provide innovative educational programs, resource management, program development, and network management in collaboration with all healthcare entities to address health disparities in whole health management. And when we look at the concept of CHWs and some of the other things I'm going to talk about, that obviously fits right in with our mission. We were incorporated in November of 1995, so we've been around for 26 years. I've been with ASPIN going on 13 years. In regard to training, back in 2002, we created one of the first case manager certification programs in the state of Indiana to address the high turnover rate. That kind of dovetails into the community health worker concept because nowadays, many case managers are considered CHWs and vice versa. We also continue to provide other trainings for clinicians in the state of Indiana, and we are certified to provide CEUs from the Indiana Behavioral Health and Services Licensing Board, the Association for Addiction Professionals, or NADAC, the Indiana State Psychology Board, and the Commission for Case Manager Certification, and the Indiana Department of Insurance, because we do have a large contingent of healthcare navigators at ASPIN, and you'll see how we leverage them with community health workers also. So we have a statewide clinical network that spans over 50 locations, serving about 69,000 consumers a year, with both community mental health centers and addiction providers. As you can see by the map of Indiana, for those of you who don't know Indiana, Indianapolis is right in the center, and our administrative offices are actually just north of Indianapolis. But our centers, our members of ASPIN, are in what's called the donut counties and the surrounding rural areas of Indiana. And you can see them listed on the slide here. Some of these are quite large, Bowen Center, Centerstone, Howard, they're all large, and then some of them are quite small. The YWCA of North Central Indiana, for example, is one of our members, and they are a woman's shelter also, along with our addiction providers. So we have a wide breadth of services and membership. I do want to talk about a little bit about the evolution, and then I'm going to dive into the history, and there will be a test later, so make sure you memorize all these dates. But as you can see, we started with actually the Certified Recovery Specialist program, and I'll dive into that in a minute, that was along with our core. And then we added health enrollment navigators, we added chronic care professionals, we added an opioid prevention and treatment recovery, and these are all grant related, you'll see in a minute. And then finally, our opioid impacted family support program, which is what we're going to do the deeper dive on today. We began training certified recovery specialists in 2009, which was 12 years ago, which was the first program of its kind in Indiana for the Indiana Department of Mental Health and Addiction. As you can see, we build on that knowledge and have added these additional certifications. Let's dive into that a little bit further. Again, because I used to be a history teacher. So got a couple slides here, and I won't read them all. I'll try to stick with the highlights. Again, 2009 is when we got things started. Nobody else really in 2009 was doing much with peers. And so we built this one from the ground up with a Department of Mental Health and Addiction grant. And we actually ran the peer certification for 8 years. We added some designations to that program in 2010 and 2011, first substance abuse and then gambling. And 2012 was kind of our watershed year. We realized, and this was, just so you know, this was a 5-day working lunch, start at 8:30, get over at 5 every day, intensive training program. But in 2012, we realized that we had a lot of people that were interested in the curriculum that we were teaching, but did not want to self-identify as peers because of stigma and many other reasons. In 2012, we did our first curriculum revision. And what we did was we broke out the CHW training into a separate but included program. So we took our 5-day program and we rearranged it. We also at that time integrated behavioral health and primary care, and we grandfathered by that time there were some other peer programs out there and some stuff from different states, and we grandfathered them in. But we took all the community health worker training and we started calling it community health worker training, and we put that into the first 3 days. And then the second 2 days, we had all of the specific peer-related training. And that's the stuff where they told their story and they talked about the recovery and those kind of things. And at first we would blend those classes together, and then we found, so that you could take the first 3 days and then you were done. We found that actually we had better training outcomes when we split them. So even though everybody got the CHW, we actually started conducting those trainings separate from, so there was a separate 3-day training. Okay, moving forward, you can see we started to get some grants. We started to bring in case managers. We started to train behavioral health technicians. That was our first grant. That was called the ARC grant, the ASPIN Retention and Recruitment Consortium. And that was our first foray into training bachelor's level people, and also the CHW training was a part of that. That's also when we started to realize that it was very hard to get people into a 3-day intensive training for community health workers. And we started to think about alternatives. So in 2016, we had another revision of the curriculum. We tried to do those every 3 years. And we started to cross-train navigators because we had gotten a CMS grant for healthcare navigators for the Affordable Care Act. And we started training all of them as CHWs because what we saw was that our navigators were starting to see a lot of people, and that they also we wanted to be able to help identify additional things and get those people help if they needed it too. In 2017, we started to do worksite visits where we would take our groups of students. Again, remember, all of this was still live in-person training. We would do worksite visits and take people to places around the state to experience that. 2018 was another one of our watershed years, and that we realized that online was the way to go. And this is proved to be very good for us in a couple of years after that. But we completely converted our core community health worker training to an online model. It's a hybrid model, and I'll talk about that in a minute, but so that you are inside an instructor and you have to progress through at a specific rate. And also Medicaid approved our CHW training for reimbursement. So if you are trained as an ASPIN community health worker, you are eligible for reimbursement for certain services. Not everything, but it's better than nothing. 2018 is also when we received one of our first big HRSA grants, and we were to train 70 community health workers annually for 4 years. And we were also awarded a HRSA Promising Practice Award for our combined CHW and Navigator training. At this point, we had so they would attend our community health worker core training, and at that point, we still had a third-party provider for our chronic care professionals. So this was a combination of community health worker and chronic care. In 2019, we became a charter member of NACHW, and I got to be an ambassador, and I still am. And we also received our second big HRSA award, and that was where another 70 a year community health workers, but this was our core community health worker training and a opioid specialization. So we had the 2 programs going. And then in 2020, we got the award or a grant for the program that we're going to do the deep dive on. And that is the Opioid-Impacted Family Support Grant. And we became at that point the first Department of Labor certified community health worker apprenticeship program in the state of Indiana. And that's a 4-year grant. And as I said, I'm going to take a deeper dive into that one. Overall, in around 10 years, we have trained about 1,300 community health workers in the state. We're kind of proud about that, and we've been doing it for a while. So our strategy, as you can kind of see this, is that we don't like to recreate the wheel. I really hate to do that. So we have always built on and improved on our core CHW program. We try to leverage our existing programs by bringing in more federal dollars to Indiana. And we also try to find out what our providers and our consumers need. And we, as you can see on the slide there, right, we do surveys of our members all the time, and we have 16,000 consumers in the network, depending, this goes up and down, who identify as unemployed looking for work. So we don't look at a grant and see, well, we should just go for that. What we do is we look for grants that we can use to make what we do better. We don't just chase the money. We go for things that we do it the other way around. We look for money to pay for what we do well. And we're always trying to look for innovative ways to meet rural workforce shortage, which is an ongoing thing all the time. And also not just the rural workforce, but we also address Marion County, which is where Indianapolis is, which is a medically underserved area. And they have a workforce shortage, particularly in these areas. So just some fun facts. We have been awarded 10 federal grants to train CHWs. We've presented to 33 different states. Again, we got that, we are a rural health information hub model. The 2018 Medicaid, 2018 Promising Practice. As far as I know, as of when I checked last, we are the only online community health worker certification program in the state. We joined NACHW in 2019, and again in 2020, first and still, I think, only Department of Labor apprenticeship program in the state of Indiana. All right, so that's kind of the history lesson. There will be a test. So I hope you memorized all those dates. One of the things I want to talk about, take a moment to talk about challenges. Community health workers have a lot, and I'm sure everybody who's listening to this knows that. You've probably heard the statistic, 125, I've heard up to 150 different job titles that apply to community health workers. And a lot of employers don't have the slightest idea what community health workers do. We have a human resources committee that meets, and it's been very interesting because one of our members, they hired a new person, a new HR director who was on our committee, and we were having a discussion, and they go, well, I don't know why I'm here. We don't use community health workers. Well, that's not the first time I'd heard that, right? So I said, well, tell me some of your entry-level job descriptions. And I can't remember what the title of the person was, but basically they go through the job description and they list all the duties. And I said, that's a community health worker. Now, when we always lead with, when we're talking to new partners, is don't get hung up on the name. What did they do? What is this person doing? Are they connecting people with resources? Yes. Okay. So even though the DOL is for community health workers, and I don't have every single competency listed out for you because I'd need a couple hours, but it's basically what we did is we tried to find out everything that community health workers possibly do, and we have a general competency along that. So one of the things that I've always tried to do is educate our students, first of all, to not just look for jobs entitled community health workers, but also, even more importantly, as I try to educate whenever I'm talking to a group or a new potential partner, is try to get them to realize that it's about the skills. But what we automatically get with this Department of Labor apprenticeship certification is street cred with employers. Everybody knows, well, most employers, I should say, not everybody, but most employers know what an apprenticeship is. They're probably more used to plumbers or those kind of things. So of course we teach them plumbing. No, I'm just kidding. It's like, oh, this person has been certified by the federal government to have a certain skill set, which had to be approved by the Department of Labor. I'm very much an advocate that by obtaining that standardized nationally recognized certification through the Department of Labor, that community health workers will benefit, as I say on the slide, by an increased understanding by employers of what to expect regarding core competencies. And when we place, as you'll see in a minute, when we place people with in an apprenticeship, the employer helps, obviously, because they have to sign off on things. They will see the competencies that this person has. Okay. Oops, sorry. Yeah, next one. So these are the participant criteria for our program. The 18 years of age is currently an Indiana requirement for community health workers. I'm actually on a work group that's talking about lowering that. They have to be a legal Indiana resident. They have to have a minimum of a high school diploma or an alternative. I know there's things other than GEDs out there when they take the test. So we actually work with some adult education and continuing education programs where people are working on their GEDs, and we've set it up so that we time it out so that before they take the test, become certified community health worker, they will have that as part of they'll have that so that they can be a legal certified community health worker in Indiana. They have to have internet access and an email address, even Gmail, which I don't really count, and we have a lot of problems with, but they have to have an email address. And what we've heard in conversations is, well, first of all, this is an hybrid online training, so you have to have those things. But we have, from when we started in 2009, we have always had an internet component to our training. It wasn't all internet all the time like it is now, but my feeling has always been as an educator that if you do not have a basic minimum competency with the internet and with technology, you're not going to be successful in your career. It is just, in this day and age, it's a given, okay, that you have to have that. And so we've always made that a part of it. You also have to commit to a 1-year full-time employment for the apprenticeship, which is critical because some people don't want to do that. And so we try to channel them into one of our other programs. The nice thing about this, as you'll see, is that there is a stipend involved with this program, but not all of them. So just kind of a review. When we developed all this, we have a team of community health workers, trainers, and other experts, subject matter experts. But these are the core competencies that we address in our training. We use HRSA, CHW competencies, SAMHSA, because even though we're not training certified peers, it's important stuff. And so a community health worker obviously is going to run into people with SUD and OUD and those kind of things. And so we want to be able them to have that skill set. And as you'll see, many of them are peers anyway. We also incorporated veterans, peer support competencies into our training. A lot of this overlap. And then obviously for certification, OMPP is the Indiana Office of Medicaid Policy and Planning. That's how we get that certification through them. These are just some of the things, and I won't read them all, but some of the skills that we train: client engagement, consumer outreach and teaching, telehealth. We have a whole module on telehealth, and that's a live module where we use a couple of different platforms for them to practice, including the phone, which is that bothersome app on your cell phone that most people don't use anymore. But we have them practice all those things. We use motivational interviewing. We have in our last curriculum revision, which was just last year, we expanded on our cultural competency and diversity training, all these things. And then we have a module on employment, and we have them do mock interviews through Zoom. So we try to be a full-featured training program. The next couple of slides, and I want to make sure I have some time for questions, but these are our training topics, and I think everybody will get a copy of the slideshow. As you can see, our core community health worker training is 19 different modules. We talk about, and since we're a behavioral health network, we hit behavioral health, SUD, those kind of things hard, but we also talk about integrated care and physical chronic health. And we do a lot on tobacco treatment. We do group facilitation, and that's both kinds, a group and then a group like this, so they can do both. And we have a whole module, we added a whole module on COVID and the role of community health workers, which gets updated quite a bit, which is kind of a nice thing that we are in control of that. Our opioid basics, we dive deeper, obviously, into the opioid stuff. We talk about RAP plans. Not that you're going to do them, but we want our CHWs to know what's out there so that they understand when they want to connect people with resources what it's about. And again, we hit stackable credentials and career ladders. So we also have a unique component is that we talk about jails, and we have a virtual jail placement. And right now, all of our placements are virtual, but we have a virtual behavioral health placement, we have a virtual jail placement, and we have a virtual traditional care. My brain just went blank there, sorry. Primary care, that's the word, primary care placement. We worked pretty hard to get because of COVID, to get a nice variety of resources there. So to specifically dive into our opioid-impacted family, these are the goals from our grant, and this was a HRSA grant. I said it's a 4-year grant. We developed new curriculum for our opioid family program. This program, because it is there's a stipend involved and an apprenticeship, we only do 25 candidates, average 25 candidates per year. And we've partnered with many, many different organizations other than the ones listed here to create those hiring entity relationships for community health workers. These are the modules that we developed for specifically for the opioid-impacted family support program. The person that's in charge of this, my coordinator that's in charge of this, is herself a peer who is in recovery, who was a nurse and was affected by opioid use, and is a family and has a family, and so she is incredible in this course and very can identify with the students, particularly those that are peers. So this is how we break it out, okay? So we have about 137 hours of didactic training, and we call that we refer to this now as our comprehensive community health worker program. And as I said, we build on things. So you can see, and these hours are estimates, but we have our core, then we run them through our opioid basics, and then we run them through, actually, we do chronic care next, and then the opioid impacted family support, and then we have them do the virtual workplace experiences, and it's right around 137 hours, but we try to get them through this in 90 days. Now, the nice thing about this is that they are receiving a stipend that is payable as they complete milestones, okay? And so this is what we call level 1. They have to complete this, and then they move on to level 2, which is the apprenticeship. They also get a stipend for this, and the stipend's a little higher for the apprenticeship, and these are paid apprenticeships. So what we do, and what my coordinator is very successful at, she's very good at this, is that we find them, a lot of times we've had several already that just get hired, and then they go through this. And these are 2,080 hours, so it's a full year commitment on top of the 137 hours of didactic. And you can kind of see, and these are estimates, and some of this is blended. So you may be working on some of your communication competencies at the same time you're doing community-based resources and those kind of things. We obviously start with the introduction, but this is their on the job, and we have a sheet of competencies. We meet with the organization. They have somebody that's their supervisor who signs off on these competencies. We have meetings. Our coordinator has meetings as the students progressing through the program. So for those of you that are visual learners, we have a visual here. We are off to a great start. The program was full in May of this year after launching in February. We have 26 students currently in the program with a waiting list for when it resets at the end of August, which is HRSA's year. Of the 26 students currently in, 3 are already certified peer recovery coaches, 6 report a personal history with OUD or another SUD, and 9 students report a family history of SUD. We've successfully partnered with 8 different organizations across the state, 6 of which are brand new partnerships that have formed as a result of our family support program. Again, these pay a stipend for the entire time they're in there, and as I said, we've already got a waiting list for when the program resets. We like to think of this as a stackable credential. I know that CHW in and of itself is a career, but we also want to say that you can take that and move forward with it or move in a different direction. You could become a certified recovery specialist, you could become a peer recovery coach, or if you go back to school or you have school already, college already, you could become a certified addiction counselor. There are a lot of different pathways that you can take with this program. I mean, our goal is for the people that serve as the apprentices will get a job with their organization. And we've seen this already with our community health worker training. One of our biggest success stories, and he's now a national speaker, he was a homeless Vietnam veteran who went through one of our first classes for our Certified Recovery Specialist program. And as I said, dual diagnosed, addiction and schizophrenia. I'm sorry, not schizophrenia. He was, my brain just went blank, and I apologize for that. But he had a dual diagnosis, and now he's married. I follow him on Facebook. He's all over the country, and he credits our program with that. So those are the kind of things I love to hear. So
thank you so much, Paul. Unfortunately, that's all the time we have.
I'm done.
Today. Thank you so much. Hopefully we'll be able to invite you back very soon to share more of these learnings with the rest of our membership. Now we're going to move on to the second part of our workshop, looking beyond social needs, unique challenges, creative solutions, and lessons learned in both urban and rural communities. Our presenters are Barbra Baumgardner and Jessica Hoskins. Barbra is a coordinator for Total Health Roadmap Special Projects at CHI St. Joseph Health in Lexington, Kentucky. She retired in April 2021 after 3 years of coordinating the Total Health Roadmap grant in Kentucky for Catholic Health Initiatives and Common Spirit Health. Jessica is a project coordinator for Total Health Roadmap at CHI St. Joseph Health in Kentucky, Lexington as well. Jessica was previously a certified community health worker for the CHI St. Joseph Health London Pediatrics Clinic and stepped into the role of project coordinator in April 2021. Ladies, I hand it over to you. Thank you so much.
Thank you. Thank you. CHI St. Joseph Health, a part of the Common Spirit, is one of the largest and most comprehensive health systems in Kentucky. Our services are highlighted in the green, and as you can see, we have a large footprint in Kentucky. Next slide. Our program is part of the Total Health Roadmap. It was a grant initiative with initial funding from Robert Wood Johnson and CHI Mission and Ministry funds. Kentucky was chosen as one of 3 pioneer sites, along with Colorado, our health systems there, and Iowa. Funding was renewed in 2020 with the CHI Mission and Ministry Fund. One of the goals was looking at social determinants of health in each market and coming up with a plan for how to address, measure, and resolve problems around social determinants of health in patients. Next slide. In Kentucky, we have 5 community health workers working with patients at 4 primary care clinics in Berea, London, Kingston, and Corbin, a pediatric clinic in London, and an OBGYN high-risk clinic in Lexington. An urban area, sorry. In all the clinics, universal screenings of patients is used. Universal screening was chosen for a couple of reasons. We wanted to ensure that everyone coming into the clinic was offered the chance to participate and receive the help. No bias on who might have needs, and trying to take away from the stigma of filling out the survey. Providers' feedback, we wanted a system that the payer agnostics to that there were no guesswork in who was eligible to be helped by the program and who would not be turned away. Next slide. Like we've said, the program began here in Kentucky in December of 2017 with 3 initial clinics, community health workers at those clinics. So we started at St. Joseph Berea. We started at Premier St. Joseph in London, and also at a pediatric clinic in London. In January of 2020, we added a 4th clinic, which was an OBGYN high-risk clinic. It was added in Lexington, which gave us both not only a different type of a patient, but also a different area, which is Lexington, which is maybe some of you all know is a more urban area. Since then, we've added 2 more primary care clinics, both in rural areas. One is in Kingston, and one is in Corbin. Next slide, please.
As mentioned previously, universal screening was adopted to screen for basic human needs, including questions not only for standard needs, but looking at the screener for dental, eye, and hearing needs, which the community health workers quickly learned were a problem and that could be successfully addressed, and thus beginning to build that all-important trust with the patients. This leads a way to addressing some more challenging needs of the patients. To date, over 32,000 patients have been screened, with a 31% having identified of one or more needs in the adult clinic and 16% in the pediatric clinic. Screeners are being included in all paperwork.
This just gives you all one example of the scope of need that the community health workers find in some of the patients. And as Paul addressed earlier, there are obviously a lot of jobs that community health workers do. You all probably know about a lot of those, especially if you are community health workers. And all of the resources that are presented here came from one patient, and it was with the help of a community health worker who basically guided her through the whole process. So a lot of times what we found is that people just don't know how to navigate the healthcare system or even where to start. So it's all important of connecting them with the resources that we all know are available for different people. Next slide.
71% of the patients that screen positive are requesting aid from community health workers. The top request need identified in all the clinics was food, followed closely by transportation and utilities.
If we take a look at the next slide, this actually shows our top needs for each of the clinics. And these are basically our 4 different types of clinics. I know we said we have more, but here's a primary care clinic, here's a pediatric clinic, there's an older adult clinic, and then there's also the OBGYN high-risk clinic. So as you can see from looking, most of those resources actually overlap and the needs overlap between the different clinics. But there are a few exceptions to that. If you look at the pediatric clinic and the OBGYN clinic, you can see that commodities was the top requested need. And I think if you think about it, things like diapers, clothing, maybe formula, those are things that would be different at those clinics. If you look at our older adult clinic, you can see that medication assistance came in second as far as a need. And again, these are older adults that probably have a bigger need for assistance, helping with getting medicines, getting them at cheaper price, kind of navigating them through the system. And then in our OBGYN high-risk clinic, which as we've said is located in Lexington, more of an urban area, behavioral health turned out to be our 3rd need that was identified in that clinic. Next slide.
To help with the biggest need for food, we partnered with God's Food Pantry Food Bank to provide food boxes in these clinics. This meant that a stopgate measured until patients can connect with one or food banks in the area. These services have been invaluable, and a lot of food banks are volunteer-based and can't always be open. So we were just helping close the gaps by having the food boxes in each clinic setting to give emergency food for like breakfast, lunch, and dinner. Next slide.
Transportation was identified as another big need for our patients. And again, we've kind of broken this down into our different areas because we have different ways to solve and resources to be used in these areas. So through the generosity of our St. Joseph Foundation, which we're very grateful to have, we have monies that are set aside that we can use to assist with all these different transportation needs. Services offered include our Uber Health in Lexington, gas cards, which we use in all of our facilities, bus transportation for our patients that are some of our rural areas, and we have a voucher system for taxi rides in Berea and London, which are two of our cities that we service with our primary care clinics. This also shows some of the differences between our rural areas in Lexington, which is a more urban area. And if you all can hear this, I don't know if you can, we're at a hospital, so you're going to hear sirens going by in a minute. So sorry about that. Basically, our urban community is just a little bit different in that we do have Uber Health, and also we have more public transportation, which is not available out in our more rural settings. St. Joseph Hospital has also just been awarded a 2-year grant from ITN America to study the transportation needs in both Madison and Laurel counties, which are where Berea and London are located. The goal of this program is to, again, study and then make transportation more accessible to people in those areas. Next slide.
Here are some examples of the wide range of resources identified for utilities in rent in our area. You may notice that a lot of the churches related resources. This is one valuable and often untapped resource to explore in your area. Most resources for utilities are rent and are county based. Next slide.
One of our other top needs was for eye and dental care. And on this slide, we've got listed quite a few ideas that might be helpful. New Eyes for the Needy is one of the national resources that we use that covers vision. The others are mainly local resources that we found through research. In looking for resources, sliding scale fees that some of the clinics have adopted, like the White House Clinic, is a big asset for some of our patients. Another area to explore is different health insurance plans. Each insurance company has different plan options that need to be looked at, especially with every age bracket. So you need to go back through and reassess as people get into a different age, like over Medicare age or whatever. It's very important to be in contact with your local government and also commercial insurance plans so that you can receive updates on what is available. For example, in our area, Anthem Blue Cross Blue Shield Medicaid has added cribs as a benefit for new mothers. Community health workers need to keep in mind that each part of the country has their very own MCOs. Next slide.
Housing is another critical in our area where resources are scarce. Resources can be explored in your community to include the Department of Housing Urban Development, HUD, and the Housing Authority. The resources are invaluable in rental assistance, public housing options, home ownership, and weatherization of the homes. Also, you can look at your advocacy groups in your area that are interested in housing, homelessness, evictions. In our area for housing, we have a committee that we are a part of that we listen in monthly meetings, and it's the Housing for the Health. Sorry. Next slide.
This just gives you an idea, a little bit of an idea of some of the more unusual partnerships that we have formed over the last couple of years. And again, this may just give you some ideas of where else to look for resources. So we had a family of 6 that had a mold infested trailer that was falling down, but they did have their own land. So we partnered with University of the Cumberlands and their summer student volunteer program to have a house built for the family. We've also worked with Goodwill Industries to help a grandfather get a felony removed from his record. And this basically cleared the way for him to apply for food stamps and medical benefits for his granddaughter, who he is raising. With the help of Lowe's and again the CHI St. Joseph Foundation that I talked about earlier, we have a fence built for a family with a mentally handicapped child so that the family could enjoy outdoor time even though they lived on a corner of 2 very busy rural roads. And then finally, we've paired with Radio Eye to get an Alexa provided for a blind person to help with turning on the lights and TV so that that person can still live independently. Next slide.
These are some of the many lessons that we have learned. Through this time with COVID, we have found that our strong connection to many community organizations has helped the community health workers find resources. Even when things were essentially closed, here are some of our lessons learned. Community health workers need to continually explore resources and build connections in the community.
As a manager, if you can arrange some volunteer work during work time for your community health workers to go out and watch and see how other community organizations work, and then also volunteer time to work in those organizations, I think that gives them an invaluable lesson as to how those organizations might work with their different patients.
And start with obtainable needs, resources to build trust and tackle harder issues.
We have found that there's a lot more resources that are obviously available in an urban area, but the community health workers have to do a lot more vetting of those resources to make sure that they're getting the right ones and you're not steering your patients to resources that might be closed or just resources that people that aren't as helpful as what you might find somewhere else. Next slide, please.
We continue to make phone calls and explore resources as one of our connections usually leads right to another. And with this being said, sometimes working with our patients, they may know of resources that would help another client of ours. So it's always good to network.
Always check on different insurance plans. We've covered this a little bit before, but just to see if you're able to move people to a plan that has coverage for what is needed. I think all the community health workers will agree that a lot of people have no idea what their insurance plan covers or what all might be available. And I know they all spend a lot of their time trying to get people moved into the right plans for them.
Find tenacious, compassionate, and local people as a community health worker. That's one of the keys of being at this job, is being drawn to it, to help.
Absolutely. And then last but not least is network. That was on there several times. I think one thing we've all learned is that don't ever think that your job is done, as you are continually finding and having to look for new resources. Next slide.
Besides helping people connect to resources, the community health workers do so much more. One of the patients in Berea summed the work of a community health worker like this: "She did a great job helping me get things done. I'm very appreciative. She has inspired me to live in spite of a lot of my health problems." Now we would like to open it up for questions and comments.
If you guys have any questions, feel free to go up to the icon where you raise your hand, and I will unmute you after I call on your name. We had someone type a question in saying, "Lovely presentation."
Thank you.
Thank you.
All right, Joshua, I'm going to unmute you.
Good afternoon. Thank you so much for your presentations. They were both very helpful and interesting. And I was wondering, maybe for in both cases, I'm sure you have worked with folks who are struggling with substance abuse disorder or substance use disorder. And I'm wondering what, just real simple, like for folks beginning to do work with folks who are kind of at the point where they're ready to seek help, what advice you would give to folks who are just kind of wanting to be supportive. I know one strategy, for example, with people who are experiencing homelessness, of course, is to focus on the housing first and then move forward, something along those lines.
Yeah. Well, one of the things that we do, and I hope I say this right, so please forgive me, is where we're in the clinic settings, when we come across someone with behavioral health, we automatically go to that provider to make them aware of that, to work with, it's kind of like we work together with the provider and the patient. We're a part of the team. We want what's best for their health. And so we would coordinate with that provider on that person, because sometimes a patient may not tell the provider, but then they open up to us. So it's kind of like we are the ones bridging the gap for our patients and helping them get what they're needing. Is there anything, did I answer it correctly? Or is there anything that?
No,
Okay.
I think.
Did that help you, Joshua?
That is helpful. And of course, I know maybe Paul might have something to say. Thank you very much.
Yeah, what we, and the lady said it very well, is as a community health worker, we train our people to network and to vet resources. And so one of the things that we try to train our people to do is to have that, hate to use a toolkit, so that they know where to refer these folks. We could have a whole webinar on SUD and OUD and have had many, but it's helping to identify, we use motivational interviewing and train motivational interviewing to find out what stage they're in, to find out if it's actually appropriate or where they are. It's still saying you can lead a horse to water, but you can't make them drink.
That's what I'm saying.
Although we just finished a webinar, for example, on working with criminal justice. And sometimes those court-ordered treatment programs work. So there's a lot of different of resources. It's just having knowledge as to what is available in your area, I think, is critical.
Yes.
Because everybody's different.
Yes. And we agree with you too on that. And that's why we work with the provider, because the provider might not have all of these resources, the facilities that might be closer for the patient, or might need to be further away to get the patient out of what is, going on in their area. And so that's how we coordinate with them. Also, we let them know, well, this looks like a good facility that marks all of the keys that the patient has said here that is affecting them. So we try like a one-stop shop for that patient.
Yeah. And we're lucky that we have relationships. I mean, all of our ASPIN members are either community mental health centers, which all deal with OUD and SUD, or addiction providers specifically. But what we're finding is so many of our community-based organizations that we're partnering with now have connections to those same resources. So again, you got to know where they are, though.
Yep.
Thank you so much. Greetings from Austin, Texas.
Awesome. Any last minute questions, everyone? Alrighty. Another comment came in, said, great presentation. Thank you so much for all you do and all your hard work.
You're welcome.
Thank you.
Yeah, thanks.
Alrighty.
All right.
Aurora, are we good? Alrighty, guys, that concludes today's webinar. Thank you so much for having the time to come in and present. So enjoy the rest of your afternoon and early evening. Have a
Thank you.
great day, guys.
All right.
Thank you.
Bye.
Bye-bye.
Bye.
Bye.
Thank you. Yay.